Globally, throughout the system, we have done 883,670 tests, and system-wide, we've tested 490,517 people for a total positivity percentage of 17.5%. And at Baptist Memphis alone, we have tested 72,380 people for a total positivity rate of 10.8%. Those numbers in positivity percentages range from 20.6% in Arkansas down to 13% in North Mississippi, West Tennessee, and 17% in the metro area. If we look at hospitalization data, they continue to look brighter and brighter, thankfully. At Baptist Memphis, we have 41 people currently with COVID in non-ICU regular acute care beds at Baptist Memphis, and there are 22 people in the ICU here with COVID.
Designed to last for up to 8 hours. With Secret, keep it fresh. Available in over 10.
Thanks. For a total of 63 people in Baptist Memphis now, which is by far the lowest. We got all the way to 152 some weeks ago, and it has been down at a very nice pace now. So of those 22 people in the ICU here, 17 of those 22 are on ventilators. We have 80 ICU beds. Only 72 of those are occupied right now, which again is a high percentage. But again, one thing that's sort of lost in that discussion is that they are very frequently at a fairly high percentage occupancy in the ICUs. And we have 80 ventilators available, and only 48 of those ventilators are currently in use. Of the 63 people in the hospital, only 3 are fully vaccinated. There were 3 COVID admissions in the last 24 hours. None of those was fully vaccinated. If we look at Baptist DeSoto, there are 38 people in non-ICU acute care beds with COVID, and there are 15 people in the ICU for a total of 53 people at Baptist DeSoto with COVID. 12 of the 15 ICU patients are on ventilators, and they have 53 ventilators available, and only 14 are in use at the moment. And as here, there are 3 people at Baptist DeSoto that are fully vaccinated, and there was 1 of the 3 that were admitted overnight that were fully vaccinated since yesterday. So those are the data that we have for today. I'm happy to answer any questions if there are any.
Hey, Dr. Threlkeld, it's Corinne. Happy October.
And to you, madam. How are you?
I'm doing all right. So, those numbers are all going in the right direction. Thankfully, we do seem to be on the other side of this wave, but I can't remember if it was last week or the week before where you said you're kind of done underestimating this virus, that we all should be too. Do we know enough now to see a pattern in these waves to maybe predict when the next one is coming? Or is it going to be another situation where we just kind of end up smack in the middle of another wave before we know it's here?
I'm hoping none of the above, mostly because I hope the second one is a negative. So there are those who've made interesting pattern recognitions out of this. Sort of there have been those who suggested, I think one researcher suggested a 2-month wave, where it would go up for 2 months, down for 2 months, up and down for 2 months. And I'm not sure that that's a reproducible situation to really be able to use moving forward, because it happens to have been that way in the past. But I think it does bring a point up that's important, and that is that it's not just what we do that affects what goes on. And I was talking to a good friend yesterday, and we pointed out that the virus in some ways does what it wants to do. We have significant impact on that by our behaviors, by our vaccine percentages and the like. But there are some things that the virus just sort of does that we don't really have as much control over and are not as able to predict. Because people who are have more isolation procedures and behavioral maneuvers to help us out, the cases are falling precipitously in those areas right now. But they're also falling in people who aren't being as careful about their behaviors. If you look around the country, so I think there's some unknowns that are just make us very uncomfortable at being able to predict what's going to happen. I think the reason for optimism is that we have no delta on our horizon like we did before. There's no clear-cut, more contagious, more dangerous variant that is sitting there at our doorstep waiting to invade when we let our guard down. And certainly if you look back at late June, we figured that things would be in our rearview mirror completely by now, the way things were looking. But we didn't account for Delta with its increased contagious situation. And when you really look at it, that's what's happened up to now, from the Wuhan variant to the Alpha variant to the Delta variant. The virus has just ever increasingly been resistant and served as a more and more effective broom to sweep up the rest of us who aren't protected, the remainder of those people. And as more and more people are protected with a still effective vaccine and a presumably effective natural immunity in most circumstances, more and more of those people are going to be resistant to the current viruses out there. Does it mean that we could have a more resistant virus come up in the vein more of the gamma, maybe lambda, maybe even mu? We don't really know the on-the-ground numbers about that. Yeah, sure. I think there are possibilities that we could see more resistant viruses that could pop up. But I think it sort of, we hope, is the way this thing ends, is that it becomes less and less severe. I think it's less likely that this virus has much in it left to be a whole lot more contagious than it is now with the Delta variant. There are a few viruses out there in human history that are recorded as more contagious than this particular variant of coronavirus. So we hope that it's at least close to its end, and remembering that these viruses have to compete with each other just as they're competing with our immune systems. So that's really what's happened before. Alpha overwhelmed Wuhan and Delta overwhelmed Alpha. And so we hope there's not a lot of that phenomenon left. And there's nothing out there right now out competing Delta in other parts of the world, much as Delta was doing to Alpha as we were celebrating the victory over Alpha at the time. So I think in that sense, it makes us a bit more optimistic. I think we might see kind of what we saw. I think that the best example in recollection might be that of the West Nile virus. Many people are old enough to remember the West Nile epidemic as it spread to our country some years ago. It was about the same time as some of the bioterrorism scare. So there was a lot of talk about epidemiology and things at that point, and we saw a great number of cases. We saw a fair number of deaths from West Nile at that time. There was a lot of concern. People were, picking up bird carcasses and testing for West Nile virus and doing mosquito control very aggressively. And for that first year or maybe two, there was a lot of attention, a lot more cases, a number of deaths. All that time, remember, the people in the actual West Nile region that gave the virus its name had sort of moved on. It was less dangerous then. It was less virulent. Fewer people were getting it. And then we saw that pattern played out here, too, over the next year or two. It became less deadly. There were fewer cases, and people don't pay much attention to West Nile anymore. We still see it on occasions, but it is much more uncommon. And generally speaking, like coronavirus and COVID-19 even, it is mostly asymptomatic even in a lot of people. So, we hope that that's what we see here too, that there's no much more dangerous variant left in this virus, and this is the way it plays out. But as you say, we've mentioned, we've kind of thought that before. It certainly has the capacity to be more resistant to our immunity, and that's where we have to keep an eye on things. And the ever-present question of, do we need a mutant or variant vaccine out there? We very well might. I frankly might have thought we would have needed one before now, rather than just another of the same shot as a booster. But we haven't. It turns out that our original boosters designed against the Wuhan variant are still holding very nicely, at least with respect to the most severe aspects, hospitalization and death, of even the Delta variant. So we hope that will play down over the coming months. I'm very optimistic. I think that we'll see by the end of this year, with the still increasing numbers of vaccines, with the advent of vaccination of kids under 12, with some continued reasonable behavior in the more risky circumstances, I'm hoping that we'll be able to have a much more normal holiday season, much in the same way that we were really having around the 4th of July before this came upon us.
Dr. Threlkeld?
Yes, Jane.
Can you talk about this link between COVID infection and increased blood sugar after the infection, and what it might mean? I know there's some research being done on it, and we often expect you to know everything.
You'd be bitterly disappointed, but But no, it's interesting because this is a very interesting thing and something that we have noticed. And I was talking to Jeff Wright, who runs the critical care unit at Baptist this morning about this. And we have a couple of patients that we have seen who presented otherwise unexpectedly with rather severe acute diabetic sort of situation, with very high glucoses in some situations, no history of same. And of course, now they're relatively young people. We've seen folks sort of across the age spectrum. And when you first see a case like that, or maybe two, you may say, well, that person had it and didn't know it, or they were about to get it, and some may have had other risk factors for diabetes. But it's something that we certainly took note of, and I had put it on a long list of things to read additionally about that might be related to COVID. And sure enough, the information is coming out now that there may in fact be a significant association. It is in fact early, but unlike some things, there are actually peer-reviewed data that are published about this topic, in addition to people just seeing this more and more around the world, and in the U.S. included. There's just an increased body of evidence in that sense, but also now there was a situation where they looked at pancreatic cells. The pancreas is the organ that actually controls insulin production and thus prevents diabetes by its function. And those islet cells that help make that insulin, it turns out when they looked at autopsy pancreas specimens from people who had died of COVID, and they also took some normal pancreas cells and infected them with coronavirus, they found that those cells began to behave differently. They were less efficient at making insulin, and some of them even contributed to an environment of inflammation that might lead to some destruction of local cells. And so it's a very, very interesting and somewhat disturbing sort of tendency. Way too early to really talk about a causative relationship just yet. But these sorts of things, my patients, the few of them are just anecdotes, but when you start to gather and organize those pieces of information, it may be that there is some actual toxicity, that some of those cells are actually infected by COVID and set off a sort of inflammatory cascade. It may be that the body is reacting to COVID-19 and actually mistakenly attacks those cells in the pancreas, a so-called autoimmune type of flare. And we've certainly experienced that in other aspects of COVID-19. We know that if the viral load gets out ahead of our immune system too far, sometimes it creates an environment of inflammation that's quite severe, and we start to sort of throw off chemical munitions around our own organs, particularly the lungs, what we think about. But it may be that this is a smaller version of that. So it's very important. We already have a lot of diabetes in this country. There are a lot of risk factors for it. But it's something else. I mean, the spectrum and sort of the horizon of side effects and far-reaching effects of COVID, we're just continuing to begin to understand. The so-called long COVID syndrome has many arms now, and this may very well be one of them, but it's something we have to look at. And once again, it's just one more piece of evidence on the now impressive pile of evidence that suggests that everyone should be vaccinated. Even those people who sort of triumphantly say, hey, I did great with my COVID, no problems, you may just not know what those problems are that might rear their head later. Even in people who don't, if this association really is true and we find out more information to support that, it could be that you might not even know about it now, but 15 years from now, when other things accumulate in your life that could make you more likely to become diabetic, this could be one more piece of the puzzle that causes you to tip over that barrier into actual diabetes. So an important relationship. We need a lot more information about it. But again, if you needed any more evidence to go ahead and get your vaccine now, which you don't, in my opinion, but if you needed any more, let this be it. Preventing diabetes may emerge as another reason to try to avoid this infection.
Thank you, Dr. Threlkeld.
You bet, Jane. Any other questions? There are a lot of questions from the feed. I'll try to get to just a few of them. Annie Billions asked, wondering if the COVID home tests are accurate. And this became a little more complicated question just the other day. We've mentioned that COVID tests in general and the home antigen tests in particular kind of share that idea that they're much more accurate when they're positive than when they're negative. So they're much more specific than they are sensitive. They will miss a lot, and there have been studies that show it misses fully 50% of the positive cases out there. The reason it can still be valuable, the home test, is that they look for larger amount of infection, potentially somebody who's more contagious. So really the best value, I think, in the home test for COVID and the antigen test, the screening test, had been for screening large groups of people. So for example, everybody on a football team in college or an NBA team, what have you, taking the test periodically, and you would pick up those people who would be the most contagious to have the highest amount of virus. You might miss some, but those people that you missed probably had less virus to begin with and might be less contagious. So that's always a trade-off, but the convenience of it, less expensive nature of it, made it, I think, very helpful in terms of screening folks and trying to prevent outbreaks in schools, sports teams, et cetera. There was one company that had a home test that had some quality control issues, and they actually had a rise in false positives. And I have pretty much preached for a long time that a positive test should be considered a positive test, not to be overthrown by a different rapid test being negative the next day. The positive test is so much more likely to be correct than the negative test. But that's part of it. They saw an uncommonly increased number of positive tests, and they went back and they said, could something be wrong here? And it turns out there was. And so that particular vat of tests has now been recalled. So you have to be a little careful about these things, but it can be shown at least that that some of these errors can be systematically found, much in the way that when we were doing PCR tests, every now and then an entire tray of tests would be positive, and the person, the operator in the lab, would look and say, that can't be right. And they would look, and sure enough, there might be a PCR contamination issue with that one run of the test. So I think still they can be very helpful, and they're much more valuable when they're positive than when they're negative at being correct. But in terms of screening, absolutely, they can still be quite a helpful thing. So thanks for that question. One person wrote, and this is something I'm glad came up because I think it's time to sort of take aim at this problem. That a previous comment was correct. 6,900 or more people have died from COVID-19 shots all along. Talk about that, doctor. And I'm very happy to talk about that. This unfortunately is a misunderstanding of the VAERS system, the vaccine reporting system that we have that's online now through the CDC and others. And what that is if you think you might have had a problem from a vaccine, you then notify that line over the internet and can report the problem. Now, there are several issues with this, and I haven't checked the number, but if 6,000 people have died after getting a vaccine, some days, weeks, or months later, that may be the broad number that this person is referring to. The problem is that it is completely inaccurate in the sense of trying to rely on that to get the real number of side effects from a vaccine. If you have 10 911 calls about somebody's back door is open, it turns out that 5 of them are going to be the dog knocked the door open by mistake, and the 2 of the other, or some other family member was inside, they didn't realize it. So many of these things turn out not to be at all related to the vaccine when you really investigate them. And the numbers that these people are reporting have not been investigated at all. And so it turns out that that number is highly, highly inaccurate. And here's the thing, even if it were to be shown accurate, even if 6,900 people had died of this vaccine since the beginning, 1 in 500 people in the United States has died of COVID-19. We had 2,000 people per day dying of COVID-19 as recently as September. So even if that were true, it would be a statistically ridiculous stance to take to say that it is more dangerous to get the vaccine than not to get the vaccine. So again, it's one of these sort of rumors that's a misinterpretation of data that even if it were correct would be a ridiculous stance to take. Also think about the fact that if you look at CDC data from the past, as recently as I think it was 2017, about 7,700 people die per day in the United States, all causes. That's just per day in the year 2017. That's before COVID-19, before the COVID-19 vaccine. But remembering again, there was an increase of about 2,000 per day as recently as September. So that changed that number dramatically. We found that the actual life expectancy of Americans, and certainly in the world, had been decreased for the first time since the 1918 influenza pandemic. So what you're looking at is a tremendous increase in the total number of people who are dying in this country, just accounted for by COVID-19 itself. And so you have to realize that when half of the population has been vaccinated, 55 some odd percent, so you got 330 million people here, you got well over 100 million people that are vaccinated. So you would expect that of those 7,700 people that die anyway in the United States, on average, you'd expect that more than half of those people would have been vaccinated. Once everybody has been vaccinated, everybody who dies in the United States will have been vaccinated, and it will be back to that 7,700 number by then, or something similar to it, and nobody would suggest that they are dying from the vaccine. So all of these things are well-meaning. I think people probably have concerns about the vaccine, but they are statistically ridiculous. And I think we have to be careful not to let people take raw data from something that may not even be true in the first place before it's even investigated, and suggest that there really is a substantial mortality from the vaccine. I'll say, as I've said many times, I have long since lost track of the number of people I have seen who died of COVID-19. And we have polled other members of the infectious disease community that we work with. None of us has seen a single admission to the hospital, let alone death, from the vaccine. So I think if we really look at things honestly, the way the data really lay out there, it's really a statistical no-brainer. But thanks for that point. Amanda Perry asked, should a fully vaccinated 73-year-old take the regular flu shot? And so, important and timely, I think the answer is yes. If they're 73, I would probably advise them to go ahead and take the higher dose flu shot that is available to those who are over 65, maybe a little more immunogenic in those folks, and last maybe longer through the potential flu season. As I think we've mentioned before, you can take them at the same time. There was the fact that in the beginning, or the advent of the COVID-19 vaccine, people said, hey, separate the COVID vaccine by 2 weeks from any other vaccine. That was purely a bookkeeping thing to make sure that side effects of COVID-19 were not going to be confused with side effects from other vaccines, which you certainly can get. Shingles vaccines, flu vaccines, other things can give you a sore arm and the same sort of symptoms. The shingles vaccine actually a little worse in the way of mild to moderate side effects than is COVID. COVID probably a little bit more than the flu shot. But now it's perfectly fine with all the data that we have. Again, 55% of the people in our country vaccinated. You can take the flu shot and the COVID vaccine at the same time. One other question Janet Butler asked, I think a very important question, are the people on ventilators elderly, or do they have underlying health issues that are causing them to be on a ventilator and or die, or do they just happen to have COVID also? And this is a very important point that's really recurred throughout the entire scope of the pandemic. I would say that there are very few people now who are elderly on the ventilators with COVID-19, because they are, by and large, fully protected by the vaccine. So those people really aren't getting severe COVID. There are a few exceptions, the very elderly, the people who were vaccinated at first, and certainly those with coexisting immune deficits or other problems that affect the immune system. So we do have the occasional person, elderly, who gets very sick with COVID. But by and large, the people who are still in the hospital on ventilators, thankfully those numbers are dropping significantly now, are younger folks who were unvaccinated. To the tune of 90 to 95% of those patients are unvaccinated people to begin with. Do they have underlying health issues? Absolutely, many of them do. I've mentioned many times weight is a significant risk factor. Other medical issues, cardiovascular, people who have really bad lungs to begin with, who get COVID pneumonia, are going to have a much more serious outlook. But I think we have to deal with that sort of complaint, objection to say that people weren't really dying of COVID. They were dying from underlying illnesses, and COVID was getting the blame. And I mean, that's the sort of thing, again, that I think demands sort of addressing. And that is to say that I work in a field in infectious disease that is not infrequently the final common pathway that causes someone to die from other underlying illnesses. Say, for example, metastatic cancer that people may suffer with for a few years even. It is not infrequent for a significant infection to jump on board and actually cause the death of such a patient. Would they have died had they not gotten that infection? Well, not then. Might they have lived 6 months, a year, 2 years In many cases, probably so. The fact that they weren't going to live 30 years and had no other underlying medical problem does not decrease the significance to, mothers, fathers, spouses, that they died 6 months earlier than they might have from their even substantial underlying disease. So the idea that COVID is not the cause of death in those people, again, I find sort of objectionable, because despite the fact that they do have underlying illnesses, they weren't going to die without COVID jumping on board and causing their death. So I think, yes, a lot of people who are the sickest from COVID do have underlying illnesses. But again, we certainly have seen young, healthy people with no obvious underlying illnesses get COVID and die from it in numbers that are enough to get your attention, and I think enough to convince even people who are young and healthy to get the vaccine, because we certainly have seen it. Just a couple of others. Kelly Phillips asked, if you got the antibiotics and tested negative, do you wait to get the vaccine? I think we're talking about the monoclonal antibody here, as far as I can tell. So if you get the monoclonal antibody and then you eventually test negative, the main thing to do there is just to wait 90 days. Without monoclonal antibody therapy, it's fine to get the vaccine at any point after you recover and they're no longer infectious to somebody else, to go out and get it. But if you had the monoclonal antibody, we recommend a wait of 90 days, purely and simply because those antibodies that we give you will be floating around in your system for maybe 3 months or so. And when they do that, when your cell produces that spike protein that is meant to energize and irritate, if you will, the immune system, get them mad and ready for the next time they see it, kind of the whole point of things, those monoclonal antibodies floating around in your system will recognize them just like we hope the immune system eventually would from the vaccine, and they will go bind to them, cover them up, and prevent our normal immune system from even finding them, and therefore from reacting to them and generating the immune response. So we want all of that monoclonal antibody out of your system so as not to hide what we're doing with the vaccine and allow the immune system to get a full response. That's really where that 90 days comes from, and the only reason you need to wait on it. It wouldn't be dangerous to take the vaccine sooner. It just might make that vaccine less effective. Just a couple more. Brenda Leister asked, why do a tracheotomy? And I think this is it's sort of an offshoot question. Tracheotomies and tracheostomies are when somebody's on the ventilator for more than about 2 to 3 weeks, that can start causing damage to the windpipe in somebody who's in the ICU on a ventilator support. And so we actually take the tube and move it from the mouth down to the actual neck. And that serves a couple of purposes. Number one, it keeps there from being damage to the vocal cords and to the trachea. And secondly, it actually will allow us to wean the support from the ventilator better. It's a larger hole through which to breathe, and it makes things easier for us to progress things more toward moving normally. It can be removed as soon as it's no longer necessary, may leave a small scar, but otherwise really no long-term problems from having had that tracheostomy or tracheotomy. So a lot of people have been encountering this, unfortunately way more than we would like in the ICU settings, because people need to be on the ventilators for a long period of time lots of times, even with ECMO and more aggressive support. And when somebody needs ventilatory support for weeks on end in the ICU, like we see now, particularly with our younger patients, tracheostomies and trach collar sort of therapy and that way to get to the ventilator support is more and more common. But it's very helpful in terms of moving things forward and progressing in their improvement along the way. So it's not something to be, you'd rather not need one, of course, much like the ventilator or the hospitalization in the first place. But if you do need it and you have that degree of illness, it can be a very nice thing to help us move forward and get you better faster. To which in that mode, Randy Higdon said, stay out of the hospitals and you will be better off. I could not agree more. It is better not to have a heart attack or COVID pneumonia or any such. I think that's a great thing. However, if you do have a heart attack or severe COVID pneumonia, I would probably still recommend that you go to the hospital. A quick point, Marty Burkett asked, what do you know about the Pfizer pill, hopefully to be released by the end of the year? There are actually 3 very nice oral medications that are in the pipeline. I can't remember whether we talked about this last week or if it came out later, but they are looking good. And of course, according to the data, the Merck product called molnupiravir is the one the most close to the finish line, I think, and the most close to FDA approval. And so far, the numbers look very impressive. It cuts the rate of hospitalization and death by 50%. in the preliminary data. And that would be a game changer to have a pill that you could take early in disease, because we have so few things. We have the monoclonal antibody, but it really is only recommended for people with significant underlying medical problems. It costs $2,000 or so a pop, not to us because the government has purchased it, but that's what it costs in the final analysis. So to have something that's cheaper, more convenient would indeed be a game changer. But I do caution against the fact that people are already saying, the stock of Pfizer went down and Moderna when this got sort of put out there as very appealing data. It is not a substitute for the vaccine. The vaccine is 90% effective or more at preventing severe illness and death from COVID-19. And no one in their right mind would take a 90% improvement in your chance of death and forego that just to get to a 50% decrease in chance of death. That would not make any sense at all. So the smart move is still to get the vaccine. And in some circumstances, particularly if you're an immune suppressed person who might not get all of that 90% in protection from the vaccine because your immune system can't generate it, then that follow-up, either monoclonal antibodies or a pill, even more conveniently, would be a great way to try to pad that improvement and improve your outcome. I'm going to skip over that one. I just have one more. Terry Hemker asks, how long are you protected for those who got COVID and recovered, and should they still get the vaccine? We've mentioned this on several occasions in several different venues. It is clear that there is a fair amount of protection by natural immunity. And so if you've recovered from COVID, you're not likely in the very near future, certainly within 3-4 months, to get that same variant. And thankfully, we don't have variants coming down the pike again as we had there for a while. Whether a vaccine or natural immunity is better, there are data that argue both ways. There's no question. There are some studies that have suggested that natural immunity is superior to the vaccine, and there are other studies that have suggested that the vaccine immunity is superior to the natural immunity. What is not really debated, and what the data really pretty clearly show, is that either way, you're better off getting the vaccine. Even if you have been infected with COVID-19, you stand a 2 to 3 times less chance of getting it again if you get the vaccine on top of this. This is why I think it's really important in folks, for example, healthcare workers. We want to avoid asymptomatic infection in folks who are taking care of other patients and could be damaging to them. And it's still nice to test people and do all those other things and the behavioral things. But if you can get a 2 to 3 times protection by a vaccine that is also safe, I would make the strong argument that it is still helpful. It is not that natural immunity is not a good thing. It doesn't work. Because it does, but you're much safer still by taking the vaccine on top of that natural immunity. So I appreciate all of those questions. Any other questions that anyone has today?
Dr. Threlkeld, I think maybe Maya had a question with the Oxford Eagle.
Sure.
Maya, are you on mute?
Maya, are you there?
Hey, Ashley, do you know what her question was?
Yes, hold on one quick second. We may have kind of covered these things. You talked about the decline in cases and hospitalizations, the pattern we can see over the past 2 years, and you've touched on that during most of the call. That was what she emailed about.
Right, and I'll just make one little extra comment about that. I mean, we see the sort of dichotomy that people sort of talk about with this is that hospitalizations are still protected against by the vaccine. And so, but the protection from the vaccine is in fact going down over the 6-month time. That's really the genesis that people said, hey, we need to do a booster. And so it gets to be very, very complicated enough to where government officials are in quite a bit of an argument about this right now. People are arguing about who all needs the booster. Do young, healthy people need the boosters? Certainly not as much as somebody older whose immune system might wane faster. And very highly qualified, smart people are arguing about that. Put the overlay in that the world needs more vaccine. Should we give more vaccine to the world? Is it better to get everybody 2 vaccines? Or part of us 3 vaccines? These are questions that aren't easily answered. But part of the reason for that is that the effectiveness of the vaccine to prevent infections at all, that is to say, keeping you from getting any version, even a very mild version of COVID-19, goes down rather significantly over the 6 months or more after you get the 2 vaccines in the case of the RNA vaccines, or 1 in the case of Johnson & Johnson. And why is that? I mean, there are basically 2 things to think about there. That is, number one, coronaviruses in general behave that way. Coronaviruses that cause the common cold, and there are 4 of them, as many will recall, you can get them again after 2 or 3 years from your last infection. They tend to be a little less severe over time, but we don't get full, long-lasting immunity from the other members of the coronavirus family. So it's not a surprise that our immunity against natural infection and or vaccine-generated infection would wane in the months to years after we're exposed to it. And the other reason for why it probably occurs the way it does, that is to say, you might get infection months later again and more breakthroughs, but you still have protection against the most serious form of the infection, is that our immune system is amazingly complex. It is among the most complex things in the known universe. It has several arms to it. You think Army, Navy, Air Force, and they do different things to protect us. The preformed antibodies that these vaccines are designed to make, we hope a lot of them neutralizing or very effective antibodies, they really knock out the virus when it first gets on the scene. And if you still have a lot of neutralizing antibodies in you when you're exposed to the virus again, you may not know you were ever exposed. You may not get any infection. And that's why it's clearly beneficial at the spread of the disease to be vaccinated, because many people, 8 times or so, fewer will have an infection at all if they've been vaccinated. So it really does knock out the infection in large numbers. As time goes by, however, that protection that completely prevents infection at all is waning, as a lot of these studies are showing. But we have other arms of our immune system left: memory B cells, memory T cells, to name the most important ones. And as you get into that next phase, you have those memory B and T cells that are primed, ready. They recognize this enemy, different pieces of it, and they're ready to amp up and recreate the army as needed. Memory B cells will all of a sudden generate a lot more antibodies very quickly. The T cells, the T helper cells, will ramp up and orchestrate the entire immune system. They control the process, make sure they are in fact playing the correct song. And then the so-called cytotoxic or killer T cells will go and destroy infected cells. Infected cells are no longer any good to us. They serve as zombies, if you will. They may look sort of okay to the naked eye, again, if you will, but to the well-trained memory T cell, it may look at it and say, oh no, there are little pieces of coronavirus on the surface of that cell. It's too late for that cell. We need to destroy it so it doesn't contribute to spreading the virus throughout our body. So these, not to mention throwing off little chemical bombs in the environment to make the place inhospitable for viral replication to begin with. So it is an extraordinary and an amazingly complicated system, some arms of which are better later than just the antibodies that we produce in the vaccine. The reason it's so complicated, and that's why we have things even like autoimmune diseases like lupus and rheumatoid arthritis, sometimes these things can get misdirected. We see that in the later stages of COVID itself, where the lungs can get destroyed or damaged because the virus had gotten off to a really, really fast start and caused this immune reaction to kind of go off on a tangent and start causing damage in the location, even in the lungs where we are. So that it's extraordinarily complicated, but thankfully, several arms of that immune system are still ready, so that if we encounter the virus again, the one arm of preformed antibodies that may not be around in as much amount anymore to prevent infection at all, those memory B and T cells will still jump into action plenty fast enough to make really, really tough sledding for this virus as it gets into its act, and finally squelch it before it is able to cause significant disease and certainly death in us. So it's an amazing system and one that is still working in terms of the vaccine to prevent us from dying of this infection. What happens a year from now later? Do we need another variant booster if there are other variants out there? Do we need another booster again, even after this third one, to keep that immunity in range as the disease still circulates around the world and could drop in on our country, much like we see with measles? You'll see occasional outbreaks in areas of the country where the measles vaccine is not taken up very well, not enough people take it, and you'll see it drop in from another country, from a visitor, and have a few mild epidemics from that. So we have to keep up that immunity to prevent the more severe forms of this disease potentially, but only time will tell how much we have to do that. Any other questions? Okay, thanks very much. Have a great weekend.
Thank you.